Okay, today we're going to review some electrocardiograms, a technology that is at least 100 years old. Dr. Coven wouldn't touch it, but it's still very useful. It doesn't tell you anything about ejection fractions or regional wall motion abnormalities, but the electrocardiogram has survived 100 years because it has some unique abilities. What's it good for?
Blocks, rhythms, and acute events.
Very good. Just when I think you're asleep, you were listening. Okay, that's exactly right. Rhythms, probably number one, and acute injury patterns. There's nothing else that's going to tell you about acute injury patterns the way an electrocardiogram would. And blocks, how the impulse, where it starts, where it ends up, if there's anything in the way. And those are the three things that will appear on this little test that we're going to have next week. And basically that's all. You know, sometimes for fun I put in a Wolf Parkinson White or something like that, but for the most part, rhythms, blocks, and acute injury patterns. So let's look at a few. And one of the things that you sort of need to keep in mind with acute injury patterns is the location. And you should be able to tell the location from the leads. One and ABL are limb leads that look at the lateral part of the left ventricle. 2, 3, and ABF, because it involves a leg lead, looks at the inferior surface of the heart. 2, 3, and ABF of the limb leads. We have septal leads, and then anterior leads, V3 through about V4, and then lateral leads, again, V5 and V6, the lateral precordial leads. So what are we looking at here on this first tracing? What's the diagnosis? Dr. Day, what's the diagnosis?
Jimmy, that's the other picture.
All right, acute injury pattern involving what part of the heart?
Lateral left, this side, that side.
It's lateral and inferior. Okay. It involves the lateral limb leads, 1 and ABL. It involves the lateral precordial leads, V5 and V6, and it involves the 3 inferior leads. Why do you think that you might get an inferior lateral injury?
Maybe circumflex.
No, it's the right coronary artery. Takes care of the diaphragmatic part of the heart, and it goes over often to the apex. And sometimes, what else is innervated sometimes by the right coronary artery? So that you get an inferior posterior. Now the posterior is a funny one involving V1 and V2, usually with ST depression instead of ST elevation. Okay, acute injury pattern involving the lateral part of the heart and the inferior part of the heart. Questions about that? Now, this is neither a rhythm nor a block nor an injury pattern. But it's often confused with an injury pattern. This is a young person, you can see at the top, 17-year-old man, who's probably not having an acute MI. He is having ST elevation, but the peculiarity here is that the T wave is completely normal. What do we call this? What?
Early repolarization.
Early repolarization. Okay, completely, as far as anybody knows, completely benign. Tends to occur in young people, not always. And you see ST elevation with completely normal T wave. T wave is not turning over. You see it most often in the inferior leads and the lateral leads, which is what it is here. And this is an excellent example of early repolarization. Stop me if things are not clear. Who sees something wrong with that, Tracy? Dr. Glenn?
Which one? There's Y.
Well, I was looking at this one, I'm sorry.
There are Y QRS complexes.
There are indeed. What's the rhythm?
The rhythm, let's see. We can see P waves, but the PR interval.
Yeah, I think you're right. You can see P waves. And you're right that the PR interval is long. So what do we call a long PR interval? First degree AV block. Okay, there are 3 blocks, first, second, and third. This is first degree AV block. What's the other block on this electrocardiogram? Louder? Left bundle branch block, okay? Now, beginners have trouble differentiating left bundle branch block from right bundle branch block. And once you get used to it, you'll never understand again why you did that, because they look absolutely nothing alike. Left bundle branch block is usually very wide and has these huge Q or S waves in the early precordial leads. And V6 is upright and V1 is upright, and they're usually sort of stumpy. I'm sorry, lead 1. They're sort of stumpy QRS complexes with a rather flat top. Left bundle branch block. Going to be expected to recognize the left bundle branch block. that another left bundle branch block?
No.
Big case.
It is paced. Atrial pacing? No. Ventricular pacing? Okay. Sometimes now it's really hard to see those artifacts, but I won't give you one that you can't see the artifact. Now that looks for all the world to me like more or less the left bundle branch block, but it's not. It's ventricular pacing, and that's all you need to say. That's the end, period. There is nothing else. You don't have to talk about a wide complex. You don't have to talk about negative deflection in the inferior leads or the lateral leads. Paced rhythm, ventricular pacing, period. The same is mostly true with the left bundle branch block. That is the end of the description as well. So we have a sinus rhythm, normal PR interval. What's wrong with that tracing?
Right bundle branch?
Yes, sir. What's wrong with it is it's a wide QRS complex, right? And the pattern is right bundle branch block. It's immediately obvious to everybody how a right bundle branch block differs from a left bundle branch block. Big R waves in the early precordial leads. V1, 2, usually 3. People like to talk about RS, R prime. There it is. There's R, S, R prime. But you don't need that. What you need is a big R wave in the early precordial leads. You need an S wave in V6 and an S wave in lead